Somebody?
That would be the sign, I believe, to start.
Hello, everybody. Welcome to another dialogue. We're talking about viral outbreaks and viral diseases. We're pretty well concentrating on COVID-19, but we're perfectly free to wander around. And we have great people to wander with. On my screen from the top, I see Peter Chin Hong from UCSF, Carlos Del Rio from Emory University. He's now the dean. And Bonnie Maldonado from Stanford, and I'm Paul Volberding from UCSF. So I think as more people join the dialogue, we're just going to go ahead and get started. And just before we opened up the dialogue, Bonnie was talking a little bit about the recent changes in COVID vaccination for children, for actually infants and young children. Bonnie, do you want to talk about that and say why you know so much about vaccinations?
Well, so first of all, I'm really excited to see that we have booster doses of what they call the updated or the bivalent booster. So that contains the Omicron strain as well as the ancestral strain for all children 6 months and older now. So up until last week, the vaccine was only available for kids 5 and older for boosters, and now it's down to 6 months and older. So the good news there is that we have primary series and boosters for all age groups. The not so good news is that nobody's really getting boosted. So we really want to make sure that that families understand the impact of COVID on kids as well as adults. So we were one of the pediatric COVID-19 vaccine trial sites. I think we had partially as a result of the community here in the Bay Area asking for clinical trials. The families were just asking for, they wanted to be part of these studies, and really we didn't advertise. People came to us and said, we really want to be part of this. And we just felt an obligation, even though I don't generally do industry sponsored studies. We thought we wanted to see the process back in 2020. Remember, we didn't know anything.
Yeah.
And we wanted to be sure that we could watch how these vaccines were being studied and rolled out. So it actually has been very, very nicely done, and happy to see the vaccines out there for kids, including
And then
boosters.
again, Bonnie, how young can the kids be for this vaccine?
So anybody 6 months and older now can
So
get
6 months and older.
vaccinated. So it's virtually all children.
So I'm going to turn to the grown-ups here, Peter and Carlos, to say what's the status of the bivalent booster for adults? A lot of us have had our booster quite a while ago now, and many people are asking about a second boost. Any update on that, either of you?
Well, let me just first go and say that my biggest concern, Paul, as Bonnie stated, is that if you look who has gotten the bivalent booster of the total U.S. population, it's only about 16%. Right. And of people over the age of 65, the people that I worry the most, who could potentially have severe complications and die if they acquired COVID, it's only about 41%. So we have a lot of people who have yet to be boosted. Now, on the other end of the spectrum, you have people like us who were boosted and are asking for another booster. So it's a really complex issue, right? Because the reality is, to people like us, I said, if you're not over 65, I tell people chill. There's no urgency. There's no rush. You're well protected against severe disease, hospitalization, and death. If you get infected, you're going to feel sick, but you're going to be, it's going to be mild. It's going to be okay. But if you're over 65, I'm a little more anxious, and I wish that the FDA and the ACIP would issue some recommendations fairly soon, because the fact is that people are anxious about it. But again, my biggest concern right now, if you got patients, if you got family members, if you know people over the age of 65 who have not received their first booster, they got to get that now. And that, to me, is my biggest concern.
I think when you look at the people who are dying in the US right now, it's 9 out of 10 older than 65, and most of them, more than 70%, haven't gotten a single booster, even though they're vaccinated. So I think that's the first thing. And the UK, always kind of an interesting bellwether of things to come. They've prioritized boosters in the spring right now for those over 75 and those who are immune compromised after older than 5. So and they said for those under 75, particularly those 16 to 49, don't bother about it. And then they may come back again in the fall.
So I want to talk a little.
Paul, let
Go
me
ahead,
just
go ahead,
mention
Bonnie.
some,
Sure,
yeah,
sure,
sorry.
sure. Yep.
One of the things that I feel is happening here is, I think as Carlos mentioned, the messaging is just not on point right now. So we're still hearing people from the FDA Advisory Committee, the VRBPAC, who are saying, well, we don't need boosters anymore. We should probably not focus on boosters based on zero data. And, what we know is that antibodies, at least at this point, we think are protective, and we know that immunity wanes over time. Now, we're not saying that we should boost every 3 months, but the idea that offhand, there's at least 2 members of the FDA committee that have just said, well, we don't think boosters should be given at all, I think is really an unfortunate message, because we don't have the data to support that fact. And we know that the boosters are safe and they do provide additional immunity. This is a respiratory virus. It's not.
Yep.
It's not, one that provides sterilizing lifetime immunity.
So thanks, guys. I think we'll get back to some of these things for sure, but I want to just kind of drop back a little bit further and say, where are we in this pandemic? Focusing on the U.S. because that's our main focus for this group. We don't hear much about it anymore. How many people are getting infected?
Oh, and I think
we're being tested, but no one's being reported. Do we have any idea really?
And I think you're going to hear less and less, right? Because as soon as the public health emergency is over on May 10th, May 11th, people say, well, nothing is going to change. Well, one thing is going to change is that the states are no longer required to submit data to CDC. And we're going to basically lose all ability to know what's going on with this pandemic because there's not going to be a data requirement, and that's going to be a problem. Having said that, there's there is interest in looking at other things like wastewater surveillance.
Sure.
Percent of people that buy rapid tests, et cetera, to know what's going on. At this moment, based on cases that we know, and cases that we know is probably about 30 to 40% of the real cases, because most people are being diagnosed at home, not in laboratories that is reportable.
Yeah.
The trends in number of cases and hospitalizations and deaths is significantly down, and I think that's a good thing to see. That's a good thing to have. Having said that, we still see not an insignificant number of cases where we are, and again, as Peter said, the biggest concern is that the people that are still dying, which is in the neighborhood of about 1,500 a week, are primarily people that are over the age of 65 and non-boosted.
So what do we know about, and I'm hoping we're learning something about the clinical severity of disease. I'll reveal that I had COVID recently, and it was very mild. I think I'm lucky. I'm certainly about 65. But is there anyone that's kind of tracking that? How is this a less serious disease than it was early in the pandemic? Is it because most of us, fortunately, have been vaccinated? What do we know about the clinical severity of this disease? Any of you? Yep.
It's not, I don't think there's any central tracking, unfortunately, other than the hospitalization and death data that we get from CDC. But there are large cohort studies that have been published over the last, since the beginning of the pandemic. And it does seem that more recent data from large cohorts does suggest that we're seeing, especially with Omicron, we're seeing less severe disease. Now, whether Omicron itself is less severe, or as you said, we have more pre-existing immunity, that's the good news. Overall, most people aren't getting ill. I think the question is, as the others have mentioned, people over 65, certainly over 75, and those immunocompromised individuals, of which there are 11 million in the US, so it's not an insignificant number of people, are just unfortunately, may be at higher risk because the vaccine may not work well, but there's also the monoclonals are just not working for those populations anymore, given the resistance to of the new Omicron variants to the antibody. So that population is really limited.
So
I
but have we followed any reports of completely unvaccinated people that are getting COVID for the first time with
I don't think,
this
I don't think,
variant?
I don't think there's such individuals, right, Paul? The,
Yeah, well, maybe not, but
the data that I've last seen data from CDC is that over 95% of the US population has antibodies either from
Right.
having been infected or having been vaccinated. I mean, I don't think you have those individuals who are totally naive. Now, there's individuals being born every day
yeah.
who are naive.
Fortunately,
Yeah, and those are individuals that you worry about because they maybe some of them have maternal antibodies, transplantation antibodies, but when they get to the age of 6 months, they're going to lose those, and that's a cohort I worry about.
so one of the another topic that I want to make sure we spend some time on, and you can guess this one, is long COVID. What do we know about? And I'm we've all seen reports now that suggest that long COVID cases with the current kind of status of the pandemic in the U.S. These cases may be decreasing. What's the group's sense of that? Is that something we can start looking in the rearview mirror about as well, or is that still something that we need to worry about?
Yeah, there
Peter, do
was
you want-
US Census data recently, people might have seen, that showed that in the earlier era, pre-Omicron, it was about 10%, and now it's about 5%. So it suggests that Omicron, together with other things that people are doing, whether or
Right.
not it's vaccines plus Paxlovid, might result in that 10% to 5%. And, even before that, there was a systematic review of about 54 studies showing that the percentage was about 6% overall, but then also some good data from Israel showing that most people get better within 12 months. So I think all of those things help me talk to patients because, again, people are really scared that it may be something that they're saddled with for life. And certainly there are millions of Americans who have symptoms that's debilitating and keeping them out of work for more than a year. But the good news is that these days it's not as bad as it used to be. And there's also some data showing that, it's kind of older data, but it's more consolidated recently. The sicker you are in the beginning, the longer the symptoms. So if you were in the hospital, I think it's like 9 months. And if you got long COVID as an outpatient, maybe you might have on average 4 months of symptoms.
And what do we know about?
The other thing,
ahead.
though, I absolutely agree with Peter. Having said that, I think there's still an urgency to vaccinate, right? To stay vaccinated.
Yep.
Because we do know that if you look at the census data for 2020 and 2021, we do see that cardiovascular disease is way up, especially among people with COVID. So it's not the tradition. I mean, I wouldn't call that long COVID necessarily, but there's certainly downstream impacts of moderate term COVID, I guess, where you get COVID and there's cardiovascular in particular and some pulmonary outcomes that are not great. And then among those populations who do, of course, we're all part of the RECOVER trials, right? The long COVID trials. And we are seeing those individuals can have up to 200 different kinds of symptoms that we don't really know how they're explained around COVID, but they're part of the catch-all definition. And we are still getting a fair number of referrals who people a year or a year out or so are still experiencing some of these. So some of them are not trivial, but the numbers are lower for sure. And again, this is why we want to urge people to get vaccinated.
So it's my sense from some of these reports that that long COVID is another post-infectious chronic or complex condition like some others. But we're also kind of getting a sense, aren't we, that any of these inflammatory conditions like acute COVID might itself be associated with cardiovascular risk. And I think, we've thought for a long time about the risk of inflammation as an underlying cause, whether it's directly from COVID or not. Thoughts on that, and does that lead us into any thoughts about treatment?
I think one of the theories about one of the subgroups of long COVID is the clotting and the, the thromboembolic state. That might also explain some of it. And then some of that is leading to whether or not, anticoagulation might be beneficial in a subgroup of people. But again, it's hard to say at this point. It hasn't really bled into treatment paradigms outside of trials.
Got it.
Yeah, I mean, I think a lot of very interesting research is being done around long COVID, and I would say that at a time where, I mean, COVID funding from the government has essentially dried out. I mean, we have no funding right now really to do better vaccine research, to do better therapeutic research. There is still funding from NIH from NHLBI specifically on the recover cohort, and the studies that are happening around that, both in pathogenesis, in natural history, and in treatment, I think are going to be critical in long COVID. So at least I feel like long COVID is going to teach us a lot about not only long COVID, but other post-viral inflammatory conditions. And, I go full circle. I think we may learn something that will help us in HIV, another chronic viral infection that has an inflammatory condition present, even when you're fully virologically suppressed. And we think that inflammasome may be a driver of some issues like premature aging and other things happening to our HIV patients. So going full circle, clearly the HIV research benefited COVID, and maybe this COVID research is going to benefit HIV.
For example, there's evidence that SARS-CoV-2 can actually, it infects adipocytes, then they can actually stimulate inflammatory pathways as well. So just this whole novel pathway of inflammatory disease around adipocytes may actually help in part explain why obesity was such a big risk factor for complications. But it does trigger this idea that perhaps we should be doing more in non-COVID related, non-specific inflammatory pathways.
And it turns out that obesity itself is an inflammatory condition, right?
Yeah.
Correct. And you touched on something, quite frankly, very important, which is this whole issue of chronic diseases, right? Diabetes, hypertension, obesity. No, it's not just a risk factor for COVID, it's a risk factor for influenza, it's a risk factor for many other diseases. So I think it also emphasizes that we need to pay more attention to our underlying chronic conditions, because part of that may explain why we had such a high mortality from COVID in our country. I mean, when you look at the mortality from COVID in our country, the excess mortality, it's only Peru had a higher excess mortality. We're number 2, and that is, I mean, it's not because we don't have excellent medical facilities. So something else was going on, and I don't think we fully understand that.
Do you think it's perhaps that we haven't paid enough attention to public health as a country?
I think it's many things, Paul. It's public health, it's enormous social inequities, it's racism, it's disparities, but it's also things like obesity, hypertension, and many other conditions.
Got it.
So I think it's not one thing, but it's multiple things happening together.
And Bonnie might have more to say about this in kids, but I remember that when Omicron first hit and a lot of kids were being hospitalized, they were much more per 100,000 than in other parts of the world, like in the UK. And part of the explanation some people hypothesized was because of higher rates of obesity and chronic disease in American population in pediatrics versus other parts of the world.
Yeah, early on with Omicron, about 50% of the kids who were hospitalized were obese. So it was a big risk factor. We know that during the pandemic also, children became more obese because there was less activity for them, especially in the lower socioeconomic groups. So that's the other issue that may be related to social determinants of health. In sub-Saharan Africa, this is related, but not directly related to COVID, is we've been able to knock down acute infectious diseases as causes of mortality and morbidity in all age groups, but now it's being replaced by hypertension, diabetes, all of those problems.
So before we go on, and I think we can still talk, there are some other issues with long COVID I want to talk about, but just to remind you, I skipped a slide at the start of the dialogue today, that IAS-USA, the organization that's organizing these discussions, has a 4-hour CME program scheduled for June 22nd. specifically on long COVID. So a chance to really dig in to some of the international experts that we've brought together on this broad topic. So do look into that. It's certainly listed on the IAS-USA website, and we'll give you the address of that later in the program as well. Back to this, and to kind of go off in a direction of treatment. Another question has been Paxlovid, both in terms of treating acute COVID, but also perhaps preventing long COVID, but also now some trials that are getting organized where longer courses are being used also in long COVID. Anyone want to tackle kind of where we are with Paxlovid? And by the way, tell us why we saw commercials in the Oscars for the not yet approved drug. Carlos, you want to start?
Well, I'll start by saying that through the Recovers cohort, the first clinical trial in treatment of long COVID will be with an antiviral. It's going to be with Paxlovid, and it's going to be a study of 15 days of Paxlovid versus not placebo. Interestingly enough, the way the study is designed right now versus ritonavir alone, I'm not sure if I would feel comfortable giving somebody 15 days of ritonavir, but apparently they want to do that because otherwise the study would not be blinded, right? I mean, you would rapidly tell who's taking the drug and who's taking the placebo. So
do you think that's ethical to give people?
I would say that I'm just saying I don't feel comfortable. I'm not a bioethicist, but I always think the proof is in the pudding. I ask myself, would I enroll myself in a study like that? And unless I was having very severe long COVID symptoms, I'm not sure I would enroll in a study like that. I mean, I don't think I want to take 15 days of ritonavir just for the hell of it. But again, you can argue that it's worth doing. But that's the one study about to start with long COVID. You then have obviously other questions, right? Do we treat with Paxlovid? What is the benefit of treating with Paxlovid? I think the data increasingly suggests that the risk of hospitalization, severe disease, and death in people over 65, even over 60, have taken Paxlovid. It's undoubtedly there's a benefit, and I think we're again underusing Paxlovid. So this goes back to why those commercials were there in the Super Bowl, because we have all this drug and we're not using it as much as we should for a variety of reasons, including people are afraid, the drug-drug interactions, people are afraid of getting Paxlovid rebound, which is not Paxlovid, it's just viral rebound, but people are afraid, so they don't take it. The second thing, obviously, is that you go to people under the age of 60, under the age of 50, and the question is, should they take Paxlovid or not? And then the data is a little more mixed, and some people still want to take it because they say it will prevent me from getting long COVID. I'm not sure that I would agree on that, and I tend to discourage people under the age of 50 who don't have underlying diseases to take Paxlovid. Now, if they're under 50 and they have a BMI of 35, I may say, yeah, definitely take Paxlovid. You're immunosuppressed. I think it's a different issue, right? But if you're talking about, somebody who is in good health under the age of 50 and has no underlying conditions, I think there's really no benefit of taking Paxlovid. And I don't see any good data suggesting that taking Paxlovid will prevent them from getting long COVID. Again, because it's such a rare outcome, right? It's pretty rare. So you need a gigantic trial to figure that out.
Yeah, going back to the trial, I mean, I'm not an ethicist either, but it seems kind of unusual to give people what you hope is functioning as a placebo, but one that causes side effects. I think generally with placebos, we try to avoid side effects, and I don't know if anyone else on the discussion today is themselves taken Paxlovid. I have, and it's not benign. I mean, there are definite side effects to the drug. So,
but it also makes me think about all those patients that we prescribe ritonavir as part of their antiretroviral regimens,
including full dose ritonavir by itself for a while until we learned that lesson, right?
But I mean, regardless of how you slice and dice the pie, not enough people who are eligible for Paxlovid are taking it, and that's probably why we have so many deaths still. Which, when you add up the number of deaths of COVID, it's estimated to be over 100,000 per year when it settles down. And that's more than the other infectious diseases combined in the US, including flu, which is like 35,000 a year. So when you look at that VA study, which showed a 25% reduction, observational, of course, in
Yep.
in long COVID, only about 20 to 30% of the people who are eligible for Paxlovid in veterans population actually were prescribed it. So I think that is the high risk group. And if we are getting 20 to 30% of that group, we still have a long way to go.
And that's a setting where people have access to high quality, free health care. So
that's
yeah,
what
and
I was
free
gonna mention.
drugs,
The
yeah.
other thing is, as we move forward, people are gonna have to start paying out of pocket for Paxlovid, and that's gonna limit the use even further, especially among those high-risk groups.
Hopefully insurance will pay for it if you happen to have
We
insurance.
hope, yeah.
And
Yeah, if you have insurance.
If you
right?
have insurance.
If you live in a Medicaid expanded state.
now what I hear from talking to Asper, again, going back to May 11th, well, is May 11th going to be like Cinderella that at midnight, the
So
carrier-
why remind us why you're mentioning May 11th, Carlos?
Well, May 11th is the day that the public health emergency disappears, right? It goes away and it's not going to be renewed. And if it was renewed, then it will happen again. But the president has already said, I'm not renewing the public health emergency. That has a lot of implications. I said one of the major implications around data. One of the major implications is around the ability to track the epidemic. But it also is going to put a lot of people out of Medicaid. It's estimated that several millions will lose Medicaid because right now you can get them off Medicaid if as a result of the public health emergency. But the good news is what's not going to happen is the government still has significant supply of vaccines and significant supply of Paxlovid. And depending on how much is used and what happens with the pandemic, whether it continues as it is, or there's a spike, estimates is that we have enough Paxlovid at the current rate of consumption to last probably through the end of the year. So at least free Paxlovid is going to continue to be available. How that's going to be distributed, how they're going to be prioritizing people, how we're going to be ensuring health equity, I think that's going to be the challenge, right? I mean, is the government Paxlovid going to be available to everybody? Is it just going to be available to people who don't have insurance? We'll have to see what exactly happens, but there is still enough Paxlovid. But I want to emphasize to our clinicians on the call the two important messages, or everybody in the call, two important messages. If you have patients, if you have relatives over the age of 60 who haven't been boosted, they need to be boosted. And if you know people over the age of 60 who get COVID, they need to have Paxlovid unless they have a very major, drug-drug interaction that prevents them. But the great majority of the drug-drug interactions I deal with, just, yesterday somebody called me, 85-year-old, has COVID, doesn't feel well. Their doctor said, no, you're not eligible. Why is this person eligible? They're taking a statin, a drug that could have been stopped, and then take the Paxlovid and do the right thing. So I think we are not using these drugs. We're not using these vaccines as we should. And we have them. And that to me is really such a missed opportunity, quite frankly, to prevent, hospitalizations, to prevent deaths still from COVID in our country.
And it could be argued that statins in an 85-year-old could be stopped anyway, right? Long time to prevent cardiovascular disease.
Exactly.
Yeah. So just want to remind the participants out there who are across the country, we have several hundred people, that the Q&A line is open. I've been ignoring it, but I'm going to try to watch that more closely and try to get your questions answered. One of the questions has been, what about the status of other drugs for long COVID? Molnupiravir, remdesivir, are those drugs, or are there other ones in development that offer some hope for this? And kind of, by the way, if you're talking about treating long COVID, does that mean that you think that long COVID is caused by chronic viral infection? It's a complicated question. Anyone want to jump in and start talking about that?
I think there are several factors associated with long COVID, and it's probably a syndrome that can be caused by different things. One is viral persistence, maybe. One is the presence of autoantibodies, kind of like a connective tissue disease, like rheumatoid arthritis. One is the association with reactivation of other viruses like EBV. And then the other is association with chronic diseases like diabetes. And then we talked about the sort of like hypercoagulable state. So each one of these might be treated in different ways. And I think that's the problem right now. A rare, relatively rare disease, even though millions are affected, like 5 or 6% now, and a hodgepodge of different pathophysiologies, each of which might be treated in different ways.
Yeah, so that to that point, I think as we talked about earlier, there's so many different manifestations and they all have different pathogenic pathways. So for example, some of the
It's
work
going to
that's
make,
been
which
done-
is going to make testing
Right.
the various theories very difficult. Yeah.
So there's two different ways you approach it, right? Do you prevent long COVID or do you treat long COVID? And you can, their question is, there are ways to do both, or we're trying to look at ways to do both. So the autoantibody story is very interesting because if you look at modeling of what predicts long COVID, that is one of the potential risk factors. So this idea of looking at autoantibodies, but not for all symptoms, just for some specific ones. For example, it's postulated that the 2 times risk for new diabetes in people who've developed COVID disease may be related to autoantibodies. And then the question is, what do you do to prevent that? I think those are questions that we're not sure of how to answer. So prevention, again, the issue of Paxlovid is still, can you prevent long COVID in those trials? The other question about whether you can treat long COVID with Paxlovid, again, as Peter said, depends on what symptoms you're talking about. So autoinflammatory disease probably will not respond the same way, but some of the other, if there's persistent viremia, which again, we don't have great evidence for that in most people, that may be a factor. But this is why the one trial that we heard about is going to be important. By the way, we reached out very early on, well, about a year ago, I guess, to try to build into recover the Paxlovid trial. And it didn't get a lot of traction at first. And it's unfortunate, as you said, to see how it's evolved, because initially it was going to be a one-site study here and we were going to use placebo. So I think because of the obvious difference between Paxlovid and a placebo, I suspect that's what led to
Would
the
have been
decision.
interesting. Yeah.
Yeah.
So
A couple of things.
Carlos, yep.
One of the things that began long COVID, one of the things that I'm excited about is, we really only have right now Paxlovid, we have Molnupiravir, where we can talk about some of the challenges with that drug and some of the concerns. And then, you have IV remdesivir, which I would love to hear what you're doing, Peter, but for us, it's just really hard to administer. It's not something that is applicable, but I'm excited about sort of this new drug, BV116, which is an oral antiviral, is similar to remdesivir in its mechanism of action. And, the study published in New England Journal of Medicine, the randomized trial showed it to be non-inferior to Paxlovid. So I think getting better agents, if it's just as good as Paxlovid and doesn't have the drug-drug interactions and the side effects, I think it would be nice to have another drug. Again,
Yeah.
we definitely need better drugs.
So
That's going to be very difficult to test, isn't it? Yeah.
So we still have our remdesivir quote unquote clinic, but as you said, Carlos, it's really difficult to get in still. The logistics of giving remdesivir, it may be the only answer for some of these very highly immunocompromised patients who do have drug-drug interaction issues. So we're still doing it here at Stanford. I don't know what you're doing, Peter, but we still have it. It's just not easy to do. And regarding remdesivir oral bioequivalence, that issue has been looked at since the beginning of the pandemic, really trying to come up with something that could be as bioavailable orally as it was IV. And really, it'll be exciting, as you said, to see what happens, because that has not been
with the new
possible
drug.
before. Yeah, it couldn't give anything orally until.
Bonnie, while you've got the mic, a question came in from Stanford, actually. Is there any talk about setting up something equivalent to the ACTG, to the HIV organized trials network, specifically for COVID, or as I think is happening, is just going to use the ACTG as the backbone for that?
Yeah, I haven't heard. So that was the initial. So very back at the beginning, right in mid 2020, I think Tony Fauci and others really pulled together ACTG and the other networks, the HPTN and others, to really try to launch studies. And they did that, by the way, for the 2009 influenza pandemic, and it worked very well because you were able to build into existing networks. VTEU, for example, could be another opportunity. But that's again, vaccine related. I think that's
Oh,
out of
remember,
that won't happen.
it's VTU, it's called Vaccine and Therapeutics.
Yeah, but
network.
and so that would be, but again, VTEUs are, it'll be interesting to see how well they can retool those networks. What they've been doing so far has been using existing networks. I don't know what you think, Carlos, but or Peter, I think the existing networks can expand rapidly to build. I mean, certainly the shell contracts are good enough to build in, and we have the expertise in these networks already, and there's at least 3 of them, so we could do that.
I really don't think there'll be an additional network.
So
Yeah,
They're expensive to maintain.
Right.
And, at the end of the day, if you ask for a COVID therapeutic network, well, guess what? Most of the people doing COVID therapeutics are us doing HIV research.
yeah,
Right.
yeah.
So
Well,
there are a
The
couple.
same people.
There are a couple really important questions I want to get to from the audience. One that we've been hearing a lot about is metformin. A drug that keeps kind of hanging out there looking for an application beyond diabetes. But some kind of interesting information. Who wants to tackle that? The metformin trial to reduce long COVID. The comment from one of the participants was Eric Topol recently really went quite far in encouraging its use.
I think the study on metformin for the treatment looked pretty impressive, and something that I would certainly consider doing for treatment. Is not yet on the guidelines, but as far as treatment for long COVID, I'm not sure. I need to review the data, but again, the problem that we have is so far, I think long COVID is, as Peter said, it's a bunch of diseases put together into one system, right? And which one exactly are we treating? I think we need to understand that. And we don't have right now, as you know, a biomarker for long COVID. I mean, those of us doing HIV have had a biomarker for a long time, and we really want to have some sort of biomarker that we can say, well, people with COVID. I mean, you remember, you and I are old enough, Paul, to remember how HIV therapeutic trials changed dramatically the moment we had viral load as a biomarker. We no longer needed to look at hospitalizations, OIs, and deaths as a marker, as an endpoint in studies. We need something like that in long COVID.
And there's no long COVID biomarker at all, right?
Well, at least that's the thought that, this recover group, but it's just been so hard, they're just recruiting, and it seems like it's been around for over a year now, but I don't think they've really come to the point where they have any really good outcome data yet on any of their cohorts.
So another question that came in is a possibility of, it mentioned, the question was Paxlovid, but I guess it could be any of these drugs as a prep for high-risk populations. Any thought about that? Having taken Paxlovid, I'm not sure I'd want to take it as prep, but
yeah, the closest thing to that was probably in household exposures and giving them Paxlovid, and it didn't really seem to make any difference. So I again, given the potential gnarliness of the drug, not gnarly, I mean, you'll take it if you have to, but it's not like a walk in the park.
So it's funny, Paul, that you mentioned that. When I read the question, and again, this is my HIV mind, I thought they were talking about somebody who's taking PrEP for HIV, who's taking tenofovir. And because we know, there's some data out there, especially from Spain, suggesting that people that are taking tenofovir are less likely to get COVID. So I thought they were talking exactly about that.
Right. So let me ask another question, kind of going back to some of our earliest discussion today. Let's say somebody has had all their vaccines and their boost. They're kind of hanging out, waiting to hear about the second bivalent booster recommendations, which I hope we hear pretty soon. But meanwhile, they develop and recover from COVID-19. Are they now protected? Does that give you the equivalent of a bivalent boost? Who wants to talk about the immunologic benefits of a symptomatic infection?
Pretty good evidence now that that infection is actually a pretty good marker of further protection over at least 3 to 6 months after infection. Probably a little better actually than vaccination, but that combination is the best, right? Infection and vaccination. So that may actually get somebody through to the fall when we hopefully will see a fall booster come through. So
Yeah,
I
no,
think the worry that I have is people who got infected just once recently and didn't get their booster since 2002. They 2020, sorry. They think that is they're good to go, but it's not, it's just the amount of reminders that you have.
Yeah.
So if you just get 1 or 2 infections and no vaccines, it's not as good, probably.
Yeah, but if you got I mean, I tell again, going back to advising people, if I tell somebody, if you took your last bivalent booster, even if it's a year ago or longer, and then you got an infection, you're probably okay. You're in pretty good shape.
Yep, I agree with that.
So another topic, I hesitate to go in this direction, but why not? That we've been hearing a lot about in the news is the origins of SARS-CoV-2. I know none of you are evolutionary biologists, but pretend you're Michael Boreby and pretend you're Bob Redfield. A comment on what do we think and do we care and why does it matter? There's a lot of discussion. Yeah.
You saw the op-ed or the little piece in the New York Times earlier this weekend. We talk about it a lot here at Stanford. Obviously, David Relman is a good friend and colleague, and we've been talking about this for some time. You don't want to deflect from everything else that you're doing, but in the end, we've asked, why do we need to know? But I think, you're going to go down the 2 paths anyway. Do we need to beef up our dual use or our research, monitoring and surveillance? Absolutely. Do we need to look at natural spillovers? Absolutely. So those 2 pathways are both critically important, but we do need to understand to what extent that work is being done around the world, and really doing surveillance to track that is important, and calling it out so that we can actually do a better job of monitoring where dual use might be, or gain of function, whatever you want to call it now,
right,
is being done. And then one person mentioned, we have almost 7 million people die here. We need to somebody needs to be accountable if there is accountability to be had. So there's more of that moral high ground piece. But I think the main issue here is to really make sure that whatever we're doing, we're investigating the origins of these viruses in a way that can help us really prevent whatever happened from happening again, which unfortunately, very likely it will happen again, but those are 2 very different strategies.
I agree with Bonnie. I think one of the arguments for knowing, and again, it doesn't change anything. We already have more than 1 million deaths, but the knowing part is like with nuclear weapons, there is a monitoring program. There's no such monitoring program for pathogens that are, BSL-4 level, et cetera, around the world. And maybe that might be the thing where you have inspections and things like that. But, there's a lot of evidence why it is spillover. I mean, as ID people, that's kind of like, in Ebola, we still don't know the answer for Ebola, and people have been looking for, I think, 60 years. So, in that sense, I don't think we'll ever really know. Plus the Chinese throw away the raccoon dogs anyway.
Yeah. You saw the recent studies that are very interesting on the link between the raccoon dogs, right, and the Wuhan market. And the virus. And I think finding that animal vector, I think, is going to be clearly important. I think just like the civet cat was, and the dromedaries have thought to be for MERS, et cetera. But, I think we need to really, it's very unfortunate that the Department of Defense had this, we think, releases based on low quality evidence. We think that this is a lab leak. And I'm pleased to hear that today the president actually is going to issue an order declassifying that information. I think we need transparency. I would also say, though, that I put a lot of blame in China. China has not been transparent. China has not been open. And if we're not transparent, if we're not trustworthy with each other, we're not cooperating with each other, these mistakes are going to happen over and over again. And we're just creating more problems. So I think international collaboration and trust is going to be critically important, because other pandemics, other viruses are going to emerge like this. And the way China, limited access and did all these things just increases the level of suspicion that something bad happened.
So let me be a little bit of a devil's advocate here. As we've as we know, as we've heard already in this discussion, this is not the first pandemic we've seen. It's not the first emerging infectious disease we've seen. I think every time one pops up, and Ebola was a good example fairly recently. There's talk about setting up a network, a global network of monitoring for emerging infections, but that really hasn't happened. Is this going to prompt us to do that?
We do have the pandemic network. I mean, a pandemic influenza network. And that's why we keep saying we already have a network for a disease that is an annual pandemic. We're now building HPAIs, or highly pathogenic avian flu viruses, into that. That network is actually reasonably robust. It's not perfect, but it's better than what we have for everything else. And I think there's a real need to really add to that, because flu we know will come, but we need to be able to pull those, and as Carlos and Peter said, bringing in more transparency. We need to have those sequences out there so we can start to track them. That's how, and it was surprising to me that China released their data very early so that we could start building, reagents and PCR diagnostics, but withholding some of that other data is not helping not only them, but the rest of the world. So
let me grab us as a group and take us from something highly political and not very applicable to daily practice to something that's very practical. Who's still masking? Are you
going to talk about the Cochrane Review also?
I am going to talk about the Cochrane Review. And I don't know. Anyway, so just for the audience, there was a review, Cochrane, which is a very careful, systematic review of published literature, scanned the literature and found little, if any, apparent advantage to masking. Does that really apply to what clinicians and those of us that are going grocery shopping think about? Who wants to tackle masks today?
So let me just
Go ahead,
mention a little
it.
bit. I just want to talk about the Cochrane Review, because I think it's being sold as something that it's really not meant to answer. The Cochrane Review was meant to review data before the pandemic, looking at how effective is behavioral interventions at getting people to mask, and how effective is that. And if you look at that information, you put it into the context of what everybody said at the end of the Cochrane Review release, which is, oh, masks don't work. Well, what I think really happened here, I at least my interpretation, and actually the authors, some of the authors are actually a little bit embattled themselves about what they think they mean also, is that there's no good evidence that what we're doing around behavioral interventions to get people to mask actually changes outcomes. I would argue that the data before the pandemic is very scant. The data during the pandemic around whether people mask or not, I think that's a very different set of data, which I don't think was reviewed in this Cochrane article. So I do think that there's overwhelming evidence, not only in real world effectiveness, but in trials that the masks work. And if you look at large population-based studies where, for example, counties or school districts that used masks versus those that didn't, when you control for seroprevalence of disease during the pandemic, there was definitely a reduction in transmission. The Bangladesh study demonstrated that mask use, although it wasn't 100%, was still provided a reduction of 30 to 40% less cases of COVID among those masking versus those not. And this is real world effectiveness. So I think the way the Cochrane Review was worded did not answer the question.
So,
but I think there's data to support that masks work.
So I'm going to say that, no, I don't disagree with you, but I will also say that I am personally masking less and less. And my healthcare system has now dropped mask and only require mask when you're in taking care of immunosuppressed patients or in certain specific areas. But, to do a primary care visit on a well individual, or a well HIV patient, you don't need to mask. You probably
so let me.
But Carlos, that's a different question. I was just going back to the Cochrane, and I agree with you.
But
we're dropping the masking out.
Paul asked who's still masking. and I
Oh,
would say-
during
I want
the,
to
during the time when nobody was
I want
immune.
I want to interrupt to
Yeah.
ask Bonnie. I think you just flew back from Houston, didn't you?
Yeah, I was in
Did-
Philadelphia, but I had layovers. Yeah, I
Did-
will mask.
Did you wear a
sit-
mask?
I double mask because I was sitting in first class because I got upgraded, yay.
Oh, why not?
But 12 of
You
us.
deserve it, Bonnie.
Yeah.
Yeah.
There were 12 of us and 5 people, including the guy next to me, who were snotty nose, sneezing and coughing. And, I know I'm not going to wind up in the ICU, I hope, but I still don't want to get sick. So I put on 2 masks. Now, did I wear a mask any other time? When I went to Europe, did I mask? No, I didn't mask by right, but I'm sitting in a little tube.
Did you go to restaurants?
Oh yeah, I haven't masked. I really haven't masked.
That's
But
the same here.
yeah.
So that's exactly what I'm doing.
But I think the Cochrane thing is different because I think it's
Yeah,
really
yeah,
important
yeah.
to make the point that masks work when they're needed. Do we need them now? I think in limited situations. And I agree with you, Carlos.
And I think this has been a really interesting discussion because I mean, I think Cochrane reviews, I mean, I've got other thoughts about the process, but you're talking about a big public health policy question, not at an individual level.
Yeah.
So I think what we're hearing is that, yeah, I think probably, I mean, this is my bias perhaps, but I think masks work on an individual level to reduce your risk of this and probably other transmissible
A good mask.
pathogens. A good mask.
A good mask work appropriately.
But can we prove in a randomized way that it works in a population? That's going to be kind of hard to do that.
Well,
I mean, it's impossible because only about 40% of the people in the trials in general were wearing
do it
masks.
anyway. Yeah, even if they
appropriately.
say they are, right.
So,
Yeah.
there's the classic epidemiologic case study of, do we know that parachutes work when you're
yeah.
jumping out of airplanes? Yeah. So what's the control
Yeah,
group?
you're not going to do a randomized study in healthcare workers.
Yeah, exactly. We're running close to the end of the hour. I want to make sure that we get to a couple of the things that came up in kind of open dialogues before we had this discussion today of other infectious diseases. I mentioned at the start of this discussion that we are interested in watching other things going on. There's been, and it came up just in passing already in our discussion, the avian flu. Avian flu is, it's raging quite a bit. There, I think, might be some risk for humans. Somebody want to tackle that and tell us about where we stand with avian flu, and should that be something that people are watching?
Well, we're watching it. The surveillance is great. Right now, over almost 60 million birds have been culled in the US because of outbreaks. It's a very sustained, long outbreak right now among birds in the US. There's only been one human case in the US this year, one I think it was in the UK last year.
Yeah, and Colorado in the
the Colorado case in the US, and both were mildly symptomatic. And we have a good H5N7 stockpile of vaccine if we need it. So it is something to keep an eye on. This is a good example, I think, of where we need to track so that we can be ready. And people have been ready. I think the companies have been ready with various HPAI serotype vaccines for this potential spillover.
So bottom line here is watch for it, but don't worry excessively, right? Yeah.
But on the other hand, the writing is on the wall eventually that this will be a pandemic, because again, we've seen there are two things. One is leaving the birds and going to mammals, but mammal to mammal transmission. And there were outbreaks in, thousands of seals, like in Spain and stuff like that. And then, so I think that is the worry, but again, nothing right now. But I think it means that we need to invest in public health and in vaccines and surveillance. And avian flu has like a 58% mortality when you look at this particular H5N1 subtype.
Another virus that's cropped up before, it's kind of hitting the scene a little bit, is dengue. A comment on dengue infection.
Global warming. We're seeing it go up crazily all over the world. The first time ever case in Arizona in Maricopa County, they saw this person come back from Mexico who had dengue only spent a few hours in Mexicali. So then the CDC came down, did this huge surveillance, and then found mosquitoes in Arizona that had Aedes aegypti mosquitoes that had dengue, and then found this person by doing serologies on the neighborhoods who had evidence of dengue but had never traveled. So I think, it's not a big surprise, but it's just kind of scary. Florida has a bunch of dengue normally anyway.
So I have a pediatric arbovirology faculty member here, and she studies dengue and chikungunya in Kenya primarily. But actually, if you look at, we have a biologist here who's really tracking the climate change issue, and we have Aedes aegypti. It's very clear we have the vector. An introduction could lead to problems. We had big dengue outbreaks in Puerto Rico a couple years ago, and now we are using Dengvaxia in Puerto Rico because it is essentially considered to be potentially endemic. The vaccine is not easy to use. It's primarily targeted to children, but it is a vaccine, and there are other good vaccine candidates that are in trials right now that we hope will actually overcome some of the difficulties that the Dengvaxia vaccine is. But it can lead to explosive outbreaks. Venezuela, the Philippines, where it's introduced, it can lead to really extensive cyclical outbreaks. So I think we have to just, again, as Peter mentioned, surveillance and tracking, but the vaccine, we need a better vaccine.
So another infection that's not a virus, guys, I don't think, C. auris, Canada auris.
Well, at least it's not cordyceps from The Last of Us.
Candida auris it's a worrisome pathogen, right? It's a worrisome pathogen because of its resistance and because of its rapid spread. There was an article in the Washington Post this morning that people are saying, we have a new pathogen. It's not new. It's been known for several years. Many people have been tracking its epidemiology and its spread in many countries. It's a very bad nosocomial pathogen. It's a very bad hospital pathogen. And once it gets into your hospitals, it's really hard to get rid of. There's cases, and then there's carriage, and there's asymptomatic carriage that moves it from one nursing home to the hospital and back. And, I think this is a new thing this is a new nightmare for our hospital infection colleagues.
It reminds me of West Nile because it used to, even though it's not a mosquito, because it used to be on the East Coast mainly. And, in the last couple of years, the number one and number two states for number of cases now are Nevada and California. So Candida auris is not a problem on the East Coast, although New York is a big state too, and Florida, but it has come to the West Coast.
Although there was some suspicion early on as this infection started to be talked about, that hospitals were actually downplaying the cases that they had for fear of driving away other paying patients. So I think I'm not sure we exactly know the nature of the epidemic or the epidemiology yet. There's a lot of discussion in the Q&A today about masks. Other people want to get back into that discussion. I think we can avoid it today, but maybe at our next dialogue we can come to it. Also, gowns. I think it raises the whole question of all the recommendations in hospital settings for personal protective equipment, and kind of, does it really work? And we know that a lot of these things do interfere to some degree with patient care because they discourage people from visiting and participating.
The most important thing that we know works, and we wish, again, it's like the vaccine, it's hand washing, right? And we need people to hand wash, and it's amazing that hundreds of years after Semmelweis, we're still having to tell people hand washing is a central part of medical care. It should not be something that's optional, yet we see colleagues don't do it, and that's problematic, Paul. And that's something that we need to continue working on. Is hand washing is an essential strategy. I do worry about isolation. I do worry about what it does to patients. So the tray that is left outside the patient room and nobody goes in, and it's problematic, and it creates a lot of stigma and a lot of discrimination for our patients. The one disease I wanted to talk about.
Can I just come back to that really quick though? A few years ago,
10 seconds.
A few years ago at ID Week, there was a really nice symposium on does PPE really work to prevent a lot of this nosocomial transmission? And I think the data were really mixed. It wasn't clear. The problem is that there isn't a lot of funding available to really study what kind of isolation measures we take. I agree with Carlos. We need to do hand washing for sure. The gown and gloves issue. Do we really need that? I think the data, I don't think the data is that great.
Let's put that on the table for our next discussion. And I'm going to bring this to an end.
I don't
With
understand.
two bottom lines. One is please get your own bivalent boost. Encourage other people, especially people at higher risk, to get a bivalent boost. And don't forget hand washing. Peter, what else do you have to say?
I think this is another
5
table, but
seconds.
yeah, Babesia also increasing in the
Okay,
Northeast
well,
and tick-borne diseases,
we'll
but
come back. We'll come back to that.
Paxlovid.
Okay, got it. Okay, thank you everyone for participating. It's been another great freewheeling discussion. Hopefully it's been helpful. And the organization I mentioned, IAS-USA, continues to have other ways to learn about what's going on. The dialogues that we have are going to continue for at least a while longer until this is all over. But I'll again remind you, I think it's on the next slide, perhaps the long COVID discussion that I mentioned earlier on June 22nd. Here we go. So again, thank you. Thanks to the IAS-USA staff for getting this all organized, for bringing these fabulous experts together, and we'll see you next time. Thanks.